by the New Zealand CLL Advocates Group. And we hope that it may be one of many to come. So we have structured it so that we have a talk by Dr. Amy Holmes. Amy is a haematologist here in Christchurch. She has worked in Australia and Canada before coming here to New Zealand, and so has got some real good international perspectives on treatment of CLL. And she became the medical advisor for New Zealand CLL advocates earlier this year. And then following Amy's talk, we will answer questions which people can either put up in the chat whilst she's talking, or after the end of her talk. And then, of course, we've got some questions that people have kindly already sent in. So it's great to have this meeting. We are really seeing an increase in real advocacy for blood cancers, working with the Blood Cancer Alliance, made up of leukemia, blood cancer, ourselves, and myeloma New Zealand. We are really managing to actually get some high-level advocacy, meeting with people like the new chair of BARMAC, Paula Bennett, and with David Seymour. So real progress. And advocacy is just so important for us to be able to make true progress in these blood cancers. And we are particularly determined to make progress in terms of CLL. So, Amy, it's lovely to have you giving a talk today. We really appreciate the effort you put into this talk, when we appreciated and realized that Mary Ann Anderson's talk was quite a complex talk, and that for people who are relatively new to chronic lymphocytic leukemia, it might have been just a little bit too complex, and really grateful that you are giving us a real overview from the basics up to cutting edge treatments. So, Amy, all yours.
Thank you, Ruth, for that very warm welcome and introduction, and welcome everyone to World CLL Day. You've got a day for yourselves, and it happens to be Father's Day, all the dads out there. So it's a great pleasure to be able to spend some time sharing some knowledge with you all, and please do put your questions in, write them into the group chat, and we'll get to them at the end. So I'll try not to take up the whole hour. I definitely won't. There'll be plenty of time for discussion towards the end. But as Ruth alluded to, Professor Marianne's talk is fabulous, but it's quite high level. We thought that we should just spend a little bit of time as well, just having an introduction to CLL for some of those people who are joining us that perhaps have had less time to become literate with the disease, because there's definitely a world of research out there, and it can take a long time to build up health literacy around these conditions. So we'll start with a little bit of an introduction regarding CLL, what it is, some of the things that we think about when we're approaching patients and prognostication, and an overview of the current treatment landscape for the disease before we move into some question time. So chronic lymphocytic leukemia is one of the most common cancers that we see in the clinic. It is the most common leukemia within adults, and it's an indolent or slowly growing cancer of the B lymphocytes, which are mature immune cells in your body. Each year, around 320 people will be diagnosed with CLL, and because it's a condition that people live with for a long period of time, that means that there is a great accumulation of patients in the community living with CLL. But whilst it's a condition of older adults, increasingly age is not a barrier for treatment of CLL. And that's one of the great accomplishments that we've made in the last 15 years in treating CLL, is that we now have a range of treatment options, even in New Zealand, which are appropriate for older patients who've got comorbidities. And that's made a huge difference to the treatment landscape for people with CLL. You can see here in the graphic, this is unfortunately UK data, but it's a pretty picture, that the cases are really starting to kick off in the 40s with very low levels of CLL before that stage. And they peak in patients in their 70s to late 70s. There's a drop-off over time in the incidence, but I think that's probably more a reflection of competing causes of death rather than a decrease in incidence. So a couple of clinical quirks with CLL. As I mentioned before, this is a condition that is indolent, it's slowly growing. And because of that, most patients will be diagnosed on the basis of a blood test. It's often been performed for completely unrelated reasons, and the GP will find that the lymphocyte count, their white blood cells, are higher than they should be. And there are guidelines and thresholds that are available for GPs to know when to go off and do the next test, which is a blood test called immunophenotyping. And we can tell from that test, with the pattern of protein expression on the outside of those cells, that this is a diagnosis of CLL. So increasingly now, patients with CLL don't need to go down and have biopsies performed if we can identify that clone in their peripheral blood. Some patients will, however, present with just nodal involvement and very little lymphocytes in their peripheral blood. And those people may need to have a biopsy of a node to make the diagnosis. A small proportion of patients will have symptoms even at the time of diagnosis, with fevers, sweats, weight loss, or fatigue. Another really interesting quirk of CLL is its immune effects. And these can occur even when people have very early stage disease. They may not justify treatment for their CLL from the outset, but they may have immune complications as a result of their immune system being disordered from having this underlying malignancy. And we see that with a condition called ITP, immune thrombocytopenia, where the immune system dysregulation causes patients to have consumption of their platelets due to the immune system. These patients may have a low burden of CLL, but may have a chronically low platelet count as a result of having the disease. Similarly, some patients will have their immune system destroying their red cells with what we call autoimmune hemolysis, or will have a low level of antibodies in their blood system and be chronically slightly immunosuppressed. And so there's a lot of bystander effect happening within patients with CLL that aren't necessarily a direct result of the burden of the disease. Additionally, a small proportion of patients will have a CLL that changes over time and may develop into a more rapidly growing, more aggressive disorder called diffuse large B-cell lymphoma. And that's worth knowing about because some patients who are living with CLL, who are under chronic low-grade monitoring, and then suddenly have a change in their behaviour of their CLL, that person needs to be assessed and worked up, because if their CLL has turned into a more aggressive lymphoma, that will dictate their treatment and change their outlook quite significantly. It's not common, but I always warn patients because it's important to identify early. So prognosis, everyone thinks of prognosis and cancer being linked to their stage, and that's true for a lot of solid organ disorders, cancers, but in CLL it actually has less of a role. And increasingly what we look at is the rate of the lymphocytes climbing and some of the genetic markers, which are much stronger prognostic factors in CLL. The staging for CLL is really based on the bulk of the disease. CLL will typically see a lymphocytosis, an elevation in their white cell count on its own, And then as the stage advances, we'll identify more and more lymph nodes, eventually enlargement of the liver and the spleen. And then at the highest stages, involvement of anemia and thrombocytopenia, where the marrow burden has increased to a point where the body's not able to compensate and keep up its blood production normally. The lymphocyte doubling time is a really handy prognostic marker. Obviously, that's not something that we can tell from the outset of first meeting the patients, but it gives an indication of the kinetics of the disease. How quickly is it evolving and growing in the patient? And that can predict, to some extent, those patients who are more likely to go on to treatment sooner rather than later. Beta-2 microglobulin is another blood test that we can use. It's cheap, easy to perform, and it's a crude marker of the tumour burden as well as the lymphocyte turnover. IGHV mutation status is a stronger indication of prognosis and can predict treatment effect as well. And so you will see IGHV mutation status recommended in an assessment of prognosis for CLL, but also separated out in a lot of the clinical studies. And those of you who have watched Marianne's presentation already will be aware that a lot of studies will separate out the outcomes depending on the mutation status, because it does have quite a strong effect on treatment response. Having said which, within a pharmac-directed drug access landscape which we live in New Zealand, it doesn't actually change our access to medications. And so it doesn't have a strong role in routine testing. Even in countries where they do have access to novel therapies in first line, IGHV mutation status is not routinely tested. It's a finicky test that requires a send away to a laboratory in Australia and takes quite a long time for the test results to come through. Even when we try to test this mutation status in the setting of clinical trials where it's mandated, often we struggle to get the result through in the appropriate time frame. Nevertheless, it's a significant factor in CLL because patients who have a mutation in their IGHV, that is that they have a CLL clone or a CLL population which has mutated and developed into a cancer at a later stage of the B-cell development, those people will have a better response to chemotherapy and really any treatments that are offered to them. And we'll talk more about that a little bit further as we go along through this talk, because it does have huge implications for the positive for these people, particularly if they're treated with novel agent, with conventional chemotherapy. Unmutated patients are more likely to have shorter duration of response to chemotherapy. And this is the group where we really have some gains to make by adding in the newer novel therapies. This group really is open to improvement in their outcomes over what they achieve with conventional chemotherapy. More relevant and definitely tested on a regular basis within the New Zealand environment is a 17p deletion and TP53 mutations. These are the strongest prognostic and predictive factor that we have in CLL. People who are mutated in their 17p and p53 deleted will have a loss of a gene that is meant to help their bodies suppress cancers. And so patients in this setting will have a more aggressive CLL with a shorter duration until treatment, but also a much less durable response when they're treated with conventional chemotherapy. And this has been recognised in New Zealand, and we do have funded first-line novel agents for the patients in this group. The 17p deletion and TP53 mutations are also something that changes as patients develop throughout their journey. Whereas HV mutation status is set because it's part of the original clone of the CLL from the outset. So these other mutations will develop inside the population of CLL cells as time goes on. And so you do see them increasing over time. And so it's something that should be tested, particularly prior to each line of chemotherapy or novel therapy being initiated. And these factors that I've been talking about can all be integrated into a prognostic score, which is the CLL IPI. And I bring this to your attention because it really does show the magnitude of importance that's placed on that 17p and TP53 mutation assessment, and that they are weighted. So any patient who carries one of these mutations is automatically in the high or very high risk group, with a much shorter time to treatment and a reduced overall survival. Having said this, the other thing that's really important to notice about this graph is that some patients will have favourable risk CLL, which will truck along for a decade and never need any treatment. And these patients can be really indolent. And so whilst there is certainly a population of CLL patients that's really important for us to see in the clinic and be monitoring and following really closely, there are certainly other people who are living with CLL quite safely in the community for many, many years. And it's worth keeping that in mind. So, as I've said, there's lots of people out there living with CLL who are under active surveillance, who don't need treatment yet. Some of them will have met a haematologist, some of them won't. And it's really important that they are aware of their condition, simply so that they can make sure that they're empowered to monitor it. The most important things when you're living with CLL is to be attentive to your general health. Exercise, eat well, quit smoking, look after your other health comorbidities. The better you maintain your health, the fitter you'll be if you do actually need treatment at the end of the day for your CLL. Part of that we were discussing prior to the session is looking after your skin, because with CLL, with that disordered immune system, your immune system's surveillance of things like low-grade skin cancers is going to be reduced. So wearing sun cream and having a regular annual skin check is really important, in addition to being up to date with the usual age-based cancer screening. Your GP should be checking on you and 6 months, but then ultimately, if things are stable, once a year is fine. And vaccination, I'm a big encourager of vaccination in patients, but especially people who've got CLL, because their immune system is just not quite as functional as it should do. And that effect increases over time, even without them having chemotherapy. And so making sure that the annual flu jab is done, and then especially when you're approaching times for treatment, the pneumococcal pneumonia vaccine is now funded for patients prior to chemotherapy in New Zealand, as is the Shingrix vaccine. And your ability to respond to a vaccine is going to be so much better before you have treatment for CLL. That's the time to vaccinate, not after you have treatment. We certainly do boost people after you've had treatment. The Shingrix vaccine is no longer a live vaccine against the shingles vaccine virus, but the response to vaccines after you've had treatment for CLL definitely diminishes. And all of this information is available to primary care physicians, to GPs. This is a direct cutout from our local Canterbury community health pathways, and I'm certain that around New Zealand in other health districts, they will have similar guidelines, which really just reiterate these priorities to primary care physicians who are monitoring a huge proportion of patients with CLL in the community. But it is important that we meet patients within the haematology clinic, particularly when they're starting to look like they're going to need treatment. Ideally, we see them for a little bit before that, because it's nice to form a therapeutic relationship before you start giving them drugs. But the threshold to treatment is really when the CLL starts to become a problem, when it's starting to cause symptoms. Treating CLL early doesn't help. It just exposes people to the immune toxicity and the other side effects of therapies earlier than they need it. People will live with that toxicity for longer than they need to. And it means that we have one less drug on the shelf when we do actually need it later on. So the indications to treat CLL is the development of anemia or thrombocytopenia, a spleen which is enlarging large enough to start to cause symptoms, enlargement of lymph nodes. It says 10 centimeters here. In practice, often it ends up being less than that. But when lymph nodes start to become symptomatic or bulky, is definitely a reason to start treating. Or disease-related symptoms. If there are fevers and night sweats or weight loss, these are all good reasons to assess someone. And the really depends on the person. As I said before, we're now living in an age where we have CLL treatment really for the vast majority of patients. Even the elderly patients are able to get treated for their disease if they're needing it. And so it comes down to assessing the fitness of the patient and their age in New Zealand. And unfortunately, in New Zealand, we are in the first line of treatment limited to chemoimmunotherapy for the vast majority of people. So people who are young and fit may be considered for a combination of rituximab with fludarabine and cyclophosphamide. Moderate fitness people will have a drug called bendamustine, and the elderly and frail are favoured for obinutuzumab and chlorambucil, where the bulk of the drug efficacy is really being carried by obinutuzumab, which is a new antibody against the CLL cells, similar to a stronger rituximab. We do have access to novel agents in New Zealand in second line. When patients progress, they can then go on to venetoclax and then subsequently ibrutinib. And so I will talk further about those medications a little bit in a moment. I mentioned before that patients with 17p deletion or TP53 mutations inherently are chemotherapy resistant. They just don't have good outcomes with conventional chemotherapy. And that's been recognised, and those patients can go on to a venetoclax in first line and then ibrutinib if they progress on that agent. Internationally, all international guidelines really identify the importance of BTK inhibitors and BCL2 inhibitors, those novel agents in first-line therapy of CLL. And that message really comes through strongly if you have watched Professor Mary Ann's presentation that's attached to this web link. And I think that is unequivocal. So the drugs that are available internationally in first-line, people would tend to combine venetoclax with obinutuzumab. That provides a shorter duration of treatment over around 12 months as time-capped therapy. Whereas ibrutinib, zanubrutinib, and acalabrutinib, they're in red, are BTK inhibitors, and those are used as continuous therapy until disease progression. More recently, people have been performing clinical trials combining different agents, and ibrutinib combined with venetoclax has been particularly interesting as a time-fixed therapy over 15 months duration as a way of reducing continuous exposure to therapy. So I'll talk a little bit more about venetoclax and ibrutinib now, as they are the two novel agents that we can access in New Zealand under Pharmac. So venetoclax first is a BH3 mimetic. So venetoclax binds to the BCL2 inhibitor, and when it the BCL2 protein, and when it binds to the BCL2 protein, it displaces a protein which triggers apoptosis, which is cell death, or within the cancer cells. And that's been a real revelation in treatment of cancer, and it's not chemotherapy based, but obviously all drugs have their own toxicities. Venetoclax was originally trialed in New Zealand in the Murano study, and this is the foundation of its funding in Pharmac, the reason why we combine it with rituximab, and the reason why it's available in second line. Although there are many studies now using venetoclax in first line, particularly in combination with obinutuzumab, where it really does have excellent outcomes. Nevertheless, this is the data for the Murano study, given that this is the environment in which we prescribe and use venetoclax in New Zealand. And you can see that the outcomes were far better with venetoclax there on the blue line than they were with bendamustine in the red. It's also effective in people who have the high-risk mutations as well. All drugs have toxicity. The main toxicity for venetoclax is that of infections, with neutropenia being particularly common at the start of therapy when patients have high burden of disease. But then you can see it diminishes there in the hatched line as time progresses. Neutropenia is a reduction in the white cells, the neutrophils, which are really your first line of defense against bacterial infections. The other thing which has been a major concern when the venetoclax medication was first in drug development is tumor lysis syndrome. And that's because when it was first being developed and we used it at a higher dose, we found that actually people's CLL cells died off so quickly that it can cause renal problems, kidney problems. And so because of this, the drug has a very gradual dose escalation program attached with it. And if this is followed, the rates of tumor lysis are really quite low. You can see them there listed at 3%. But it does have relevance to the commencement of venetoclax, because those of you who are on it will remember there are a lot of blood tests at the start, because you really do need to be monitored quite closely at the start for this kidney strain that can occur with venetoclax. Moving on to ibrutinib. Ibrutinib is a small molecule, and it binds to a protein called BTK, which blocks the signaling that comes through the B cell immunoglobulin receptor. And that's an intrinsic pathway which is turned on in CLL and drives the survival of the CLL cells as well as their replication. And so by blocking that pathway, it leads to death of the cancer cells, which is our end game. It's different to the other medications because this medication is really taken continuously until disease progression. So the implication of that is that people can be on these medications for years and years. It is very effective, interestingly, because that it also changes the relationship between the CLL cells and the microenvironment. When people first start out on ibrutinib, actually their lymphocyte count climbs. And that's because the lymph nodes will be shrinking and there's a redistribution of the CLL throughout their body. So a transient lymphocytosis is expected. Similar to venetoclax, it is effective in overcoming the high-risk mutations. And there are newer versions of ibrutinib also funded internationally, the second generation BTK inhibitors, zanubrutinib and acalabrutinib, which really have the benefit of improving some of the toxicity profile. Zanubrutinib is possibly slightly more effective than ibrutinib, and acalabrutinib certainly has an improved cardiovascular toxicity profile because ibrutinib can cause atrial fibrillation and high blood pressure in a reasonable proportion of patients. And it also impacts on the platelet function with off-target effects. And that can then become a little bit of a juggle when you have patients who've got atrial fibrillation needing anticoagulation, but then also taking ibrutinib, which is inhibiting their platelets. So bleeding is another concern. But again, I've mentioned infections many times tonight. Infections is another consideration with ibrutinib, and particularly because people are on these agents for such a long time. And the rate of infections is increased in the first year, but you can see there in the grey, even out at 5 years of being on ibrutinib, there's still a 10% rate of significant infections, 1 in 10 people having a significant infection each year. So no drug is without toxicity. So, but it is clearly effective. So this is one example of one of the first-line ibrutinib studies. There are many studies of BTK inhibitors as well as BCL2 inhibitors being used in first-line. And again, I divert you to Marianne's talk for a more thorough, comprehensive review of all of the studies. But I've used this one here just to prove a couple of principles that we've talked about, because really, the vast majority of the studies all show the same thing. And that is that BTK inhibitors and BCL2 inhibitors both have excellent outcomes. The line in red is the ibrutinib with rituximab line arm. And you can see that that's clearly above the blue line, which is the general population in section A. I'm not sure if you can see my mouse, so I'll stop using it. In graph B, it highlights to you the difference in the impact of the mutation status. So in patients who are unmutated, this is the group that had the most to gain from having ibrutinib. The IG mutated group down in panel C really has pretty similar results between RFC and ibrutinib. And it's only when you get out to a really long follow-up out at 7 years that it started to become statistically significant. For the majority of the time, actually the outcomes between the two groups were the same. And that's quite significant when you're talking about RFC, which is a 6-month course of treatment in patients, and comparing it to people who have been on drugs continuously for in this study 7 years. So we shouldn't do cross-trial comparisons because every study has a different population group. And so you really can't equate the outcomes from one study with another study. But nevertheless, we often do. And that's partly because especially in this setting, it's good to get a bit of a flavour, a bit of a feeling about what the expected outcomes are with all of these different chemotherapy regimes. So I've pulled out a couple of the big studies. And these are the median survivals that we expect to see or have seen in those studies. Median is basically the 50%. So 50% of the patients on these studies will have done worse than this outcome, and 50% will have done better. So it's certainly not to say that everyone's going to be progressing at this time. The other thing to note about this is that this is progression-free survival. It's not time to next treatment. So when you look at the outcomes, these patients will have shown disease progression with slight enlargement of a lymph node or a slight increase in their lymphocytes at this time point, enough to define them as progressing. But they may then have been monitored for many years before actually needing another line of chemotherapy or immunotherapy and a further intervention. So that's worth considering, particularly when you're looking at treatments such as obinutuzumab and chlorambucil, which in this study was used in an elderly age group. And if you've got patients who are well into their 80s and you're using a medication combination that's going to give them 3 years before their disease is going to progress, and then you're going to monitor them for a couple more years after that, well, actually, probably the fact that we're avoiding these newer agents in that group is okay, because the outcomes with all of these conventional chemotherapy arms are actually fairly reasonable. Having said which, it's clear that the novel agents, which are there in bold in first line, do have better outcomes. Venetoclax obinutuzumab combination, ibrutinib continuous, and the ibrutinib venetoclax combination, all at 5 years, had not reached their median progression-free survival yet. At 5 years, they still had 60 to 75% of patients who had not yet progressed from their disease. And so clearly these newer combinations are pushing the barriers of treatment response and really are very effective medications. I will, though, call your attention again to the IGHV mutations outcomes there. If you look at the top line, the rituximab with fludarabine and cyclophosphamide group, and one of the earliest studies using that combination was one done in 1999 by the MD Anderson. And when they separated out the IGHV mutated group, actually those patients have really extended periods of survival without further progression. So the median progression-free survival in that study was 14.6 years if you were mutated. Clearly better than if you were unmutated. That group only had 4.2 years, still a long time. But this has relevance when we think about the cost of treatment, because 6 cycles of RFC chemotherapy is going to cost $5,500. And you only have 1 line of treatment, and then you've got 14 years with no therapy, comparative to 14 years of continuous ibrutinib therapy, which is going to come out at an astounding $2 million. So you can understand some of the hesitancy when you see this of putting novel agents into first line when you're potentially having huge costs of continuous therapy. This is the attractive component of using time-based therapy, time-limited therapy, such as the obinutuzumab and venetoclax arm, or ibrutinib and venetoclax combination, where really your treatment is condensed. And there is a study under recruitment at the moment, the CLL17 study, which will look at these 3 new agents in first-line treatment for CLL, and we will hopefully see the result of that in coming years. So novel agents are great, clearly, but not accessible in New Zealand. And as you can see from the costings that I've provided, also difficult from a financial perspective for the majority of patients. So clinical trials are an excellent way of accessing novel therapies, and all trial centres around New Zealand will be enthusiastically taking up CLL studies if they're able to. And I'll call your attention to the clinical trial refer app, which you can download or you can access through the web. Because this, which is an Australian-based clinical trials site is now integrating in the New Zealand trial sites as well and keeping them up to date, which makes it much easier to see what studies are open and around New Zealand as well. Generally speaking, clinical trials will only take patients with CLL who are actually progressing to the point where they need therapy. So even if you have early stage disease and there's a study open in your site, it's likely not to be relevant to you until you actually need treatment for your condition. But it is worth being aware of this, particularly if you're happy to travel around New Zealand in order to access care. So in summary, CLL has really advanced dramatically over the past 10 years. We've got a lot of progression. And there really are further advances available on the horizon. They will eventually translate into a Kiwi space. And so it's an exciting disease space to be working in. And I'll stop at that point and open up to questions. Hopefully, Ruth has been collating your questions whilst I've been prattling along.
Oh.
Ruth, I think you might be on mute if you're trying to talk to me.
No, I'm not on mute, but I managed to actually, well, I was trying to go to see if there were any questions, which there don't appear to be. Actually there, although we have some already sent in, I managed to completely remove myself. So can you now hear me?
Yes, I can. Yes.
So I'll have to talk to you without actually being able to see any of you. So I do apologize. Thank you, Amy. That was a fantastic talk. I really, really enjoyed that. And hopefully the people who are listening who have had less information about CLL than some of us will really get an idea of just the whole nature of this condition. It's a condition which can be a horribly aggressive condition. It can be a condition which is actually a very benign condition which people live with for years and years and years and don't need treatment. So really a wide spectrum, as Amy has said. So I think one of the areas that we have been really lucky here in New Zealand over the last few decades is being able to take part in clinical trials. What clinical trials do you know are available at the moment? And
so in the CLL space, I don't think there's a huge number. There is a clinical trial that's still open to recruitment, but probably closing soon, which is looking at a combination of soronatoclax, which is a newer medication along the lines of venetoclax. It's another BH3 mimetic combined with is it ibrutinib or zanubrutinib now? I'm not.
Oh, sorry.
With ibrutinib, isn't it? And that's compared against venetoclax with the obinutuzumab. So that is still open, but the recruitment rate to that is slowing down now because they're recruiting more heavily in the North Hemisphere. I think we filled our New Zealand and Australian quota a little bit too fast for them. The only other study that we have open in Christchurch at the present is a venetoclax study with looking at 17p deletion, which is really just the third arm in a study where the main primary arms have already closed. So it's quite limited in the patient group that it's targeting.
And there are some other trials available in other parts of the country. One of the things that as CLL Advocates New Zealand, we're very keen to make sure happens is that patients, if they want to travel to other places, can travel and that they get financial support. And certainly Leukemia and Blood Cancer has been very supportive of that. And we have been talking to Health New Zealand about trying to make sure that patients can move about. So if patients find that they are having problems moving to another centre, please let us know, and yes, and we can advocate on your behalf, because yes, it's really important that if treatment is available elsewhere, this was the whole point of having a national health system, that yes, patients can get treatment wherever it's required. So
that's right. And some studies actually encompass that. And so part of health equity, particularly in regional areas, is improving access to these treatments. It does come with some limitation, but because increasingly CLL studies are oral-based treatments, we definitely have patients on the West Coast and in Nelson Marlborough who periodically will travel to Christchurch, but for the most part are having their therapies at home ongoing.
And the other thing that we're working very hard with in terms of both for example, the Australian Leukemia and Lymphoma, the Australasian Leukemia and Lymphoma group, but also the companies, is to actually try to get follow-up where appropriate by video. And that's something that's, yes, because obviously Australia is such a big country that the Australasian group has really taken that on board. So Mark, welcome. It's lovely to have Mark Pierce online. You have forwarded us a question, which is really sort of saying, having watched Professor Marianne Anderson's talk, you know, are the standard treatments here in New Zealand of any use? Are they okay to be using? Where are we at? Do you feel that you have had the answer to that? I mean, as you said, it is within the limitation of drug funding within this country. And it's very difficult to actually know how much of an increase in drug budget expenditure we're going to be able to get. I've been very grateful to the efforts of people like Catherine, who's been working very hard to try to influence things behind the scenes. Catherine Isaac, who's the chair of CLL Advocates New Zealand, to try to get the people who are in a position of influence to actually understand the issues in terms of drug funding. And as you know, we have had an increase in Pharmax funding, but it has only taken us from 30% of a country that has got an equivalent GDP, such as the UK, up to 33%. So our drug budget is still well down.
Yeah, it's a major concern within CLL, but across the whole scope of cancer treatment. I think your initial question of should BCL2 inhibitors and BTK inhibitors be first line is clearly borne out in the studies that patients do better on these agents. The gain is mostly seen in those with IHV unmutated CLL. Although if you stretch the follow-up long enough, eventually you see a bit of a benefit in the IGHV mutated group as well. And chemotherapy is certainly toxic. If we can avoid providing chemotherapy to patients, we prefer that. There's definitely risks associated with first line combined chemoimmunotherapy. And that's especially the case with the fludarabine type chemotherapy that we use in the youngest audience, where it carries a small but real risk of long-term myeloid malignancies, where people can have a secondary blood cancer as a result of their chemotherapy that they're exposed to. That's seen in about 6% of people who have that chemotherapy. And so if we can avoid that, absolutely, we would favour that. I think on your discussion regarding the funding of medications, I think the attractiveness of venetoclax with obinutuzumab or ibrutinib with venetoclax really is increased, and CLL17 will be particularly helpful to know that those agents are, and that combinations are equivalent to continuous first-line BTK inhibitors. Because when you're proposing any drug that's expensive and then someone's going to be on it for decades, that's a hard thing to get across the line. Whereas even though it's not cheap to have treatment with ibrutinib combined with venetoclax, for example, your cost really still only adds up to, I think, around $250,000. And then that will be your only line of therapy for 5 to 10 years. So perhaps that's a little bit more realistic.
And indeed, if you have the mutation of the IGHV gene, it might be a lot longer before you need treatment. But I guess that data is not completely through yet. We've got a question about whether outcomes are, this is from Gordon Speed, thank you, Gordon, whether within the limitations of drug availability in New Zealand, is there a difference in outcomes that can be measured? And I mean, I guess we've got the trial data. What we don't have in this country is good ongoing data.
Yeah.
And that's one of our frustrations.
We don't have a registry for CLL. So within the myeloma space, we can now show that there's actually a survival benefit of being in Australia comparative to New Zealand with their expanded drug access for myeloma, because we have an excellent myeloma registry where all of the patient data is collected. Registries are a big undertaking. They take a lot of manpower, and it takes many years to be able to collate enough evidence to show a difference. And we don't have that in CLL. Having said which, even if we did, the vast majority of the CLL studies do not show an overall survival benefit, even though there is a progression-free benefit between the two arms. And the reason being, even though people may be treated with chemoimmunotherapy in the first line, and perhaps they've had disease control for 3 or 5 years, they then progress on to a different agent and respond again to a second line of therapy and have another good response. And so we're getting to the situation now where it's actually pretty uncommon for people to die from CLL. They may die from other complications, such as infection, but from disease, lack of disease control, it's actually not very common. In the majority, the people who are particularly young presenting with CLL, those are the people who I suppose have the most to gain from having a really long, durable control of their disease.
And indeed, if those young people are unmutated, it's so important that they get onto some really top-line treatment. PBNZ were keen to do an article, which I don't think they have actually put on the news as yet, about a couple of our young patients who had very nasty disease and managed to get on clinical trials. So yes, our thoughts are particularly with them today on International CLL Day. And we're very grateful to both those lovely patients who've been willing to speak to TVNZ. So, and that takes us on to the next question, which is, thanks, Amy, for your talk. Is there a view on why there's more younger people with CLL now being diagnosed?
I'm not sure if there necessarily is, or whether we're just better at picking it up. I don't know that there's any evidence to say that there's more young CLL patients now than there were before. Possibly also because there's more treatments available. People are sort of getting onto it a little bit higher, but it's not something that I'm aware of. If there is a study that shows that, I'd be very keen to see it.
I agree. I haven't seen any data actually showing that.
But we certainly do see patients who are young presenting with CLL. I've a collection of 40-year-olds who have CLL. So it's not unheard of. Whilst we consider it a disease of older patients, you know, it does start young sometimes.
So I might follow up on that question and see if I can find some data. There must be international data. So yes, we'll look into that and get back to you in terms of the incidence and whether it is increasing. We do know that with a number of malignancies, the age group is definitely, age of diagnosis is definitely dropping. But I agree with Amy, I haven't seen anything for CLL. So one of the other questions is, what role can advocacy group play in supporting research and treatment advances in CLL?
Yeah, go on.
So Amy, over to you.
Oh, so I mean, a good question. I suppose I see advocacy groups as having a role of becoming a patient voice, because we're all stronger in numbers, and so it's a source of support and collegiality, and information, and also I suppose becomes then a tool as well for pushing forward advancements that need to occur. For example, trying to continue that pressure to expand drug access within New Zealand, and making sure that the patients are having a voice within that journey. Ruth, do you have any other comments? Those are my thoughts, at least.
I think what we've seen in the last sort of 20 years is just such a fantastic increase in patient advocacy groups. It's just been great to see just how much influence patients are having. And I think I'm going to use this time to just say to all of you, yes, we are looking for another trustee, but also for a group of people to actually be a patient focus group to guide the trustees. So we sent out an email, and we will just include the people who have just signed up to this webinar who perhaps didn't receive the first email, and then we hope to actually Zoom with the people who've indicated that they're keen in the next couple of weeks. So it would be great to have you people on board, because yes, this is a patient group, and I feel very privileged to be part of this group. I'm very grateful that Amy is our medical advisor, but it is a patient group. So yep, fabulous that a number of people have put up their hands to be either a trustee or a part of that group. Another very good question, and I don't know the answer to this, except that I haven't seen a positive, anything positive in the literature, but I maybe just missed it. But Gordon has said there's been a recent report from Israel suggesting that people who took vitamin D had longer time to treatment. If there's strong enough evidence for people to start taking vitamin D to try to slow down progression.
I've not seen that study. Having said which, vitamin D is pretty innocuous, and I'd be willing to bet that we're all deficient in New Zealand. So it's probably not something that's likely to have great harm associated with it. And vitamin D supplementation has been suggested to have a huge range of various benefits, albeit with variable quality of the data and the scientific merit behind them. So I think vitamin D is definitely something that's actually supplemented in diets around the world, particularly in countries like Canada, but surprisingly not so much in New Zealand. And I think I know that my vitamin D level is very, very low. I'm sure that most of yours are too. You need to have quite a lot of sun exposure to get your levels up. So probably in that space of questionable benefit, but potential low harm. So I wouldn't be opposed to my patients taking vitamin D. Definitely not. In fact, I actively encourage it.
Coming from Dunedin, he is probably in even greater need of some vitamin D supplementation.
Yeah, that's right. No, so that's interesting. I haven't directly seen any evidence for it, but that's not to say that there isn't a study out there that I haven't heard.
Gordon, I've been really keen to see that study, and if you were able to pass that through, and yes, I'll do some more research and get back to you about that one. And then finally, Amy, the last question is, are there any emerging technologies or approaches such as CAR T-cell therapy that could be a real game changer in CLL treatment?
Yeah, so I don't know that there are. So CAR T-cell therapy for CLL, I think has been tried from time to time to be and BiTE in antibodies as well, which are similar to CAR T-cell therapy. They bridge between the immune system and the cancer cells, and then use the immune system to destroy the CLL cells. I don't think that there are great advances in CAR T-cell therapy yet in the CLL space. It's a bit more complicated to use CAR T against CLL in that there's so much more immune dysregulation happening, and particularly with the chemotherapy exposed patients, they're harder to manufacture in the setting of fludarabine and bendamustine exposure. So I don't know that the research is going down that line just yet. Those treatments are also quite a lot more toxic than a lot of the small molecule approaches to treating CLL. But there are certainly lots of new other targeted agents sort of coming through. Pirtobrutinib is a BTK inhibitor, which is doesn't covalently bind to the BTK molecule. And so because of that, it overcomes a lot of the resistance mutations that people can develop with CLL. We mentioned Soronatoclax before, which is a new BCL2 inhibitor. There are other small molecules targeting other pathways upregulated in CLL. So there will be more and more drugs coming out in this space. I don't think any are looking curative at the moment. Even CAR T-cell treatment probably wouldn't be. So those things are sort of far away, I think, in the future. They're not in the immediate next couple of years.
Yeah, I mean, it's interesting that the good old FCR for mutated patients, there's talk that maybe those patients who've got out to beyond 10 years, and that's when relapse is beginning to be really unusual, maybe they are actually cured. So yes, yeah. I mean, it's interesting for, but I guess the patients that one would be looking at these aggressive treatments would be the unmutated patients who have just such horrible disease, a very different type of disease.
That's right. And I mean, if you're looking at something that's as toxic as something like CAR T-cell therapy, the group that would be sort of the focus for that in the international landscape would be people who have passed through both a BCL2 inhibitor and a BTK inhibitor, and they're looking at third or fourth line therapies. But actually, we've only had these new drugs for the last decade, so perhaps the need for that's not quite there yet.
Right, Amy, that's excellent. I think, as there are no more questions that's come up, Gordon, thank you so much for sending through that reference. I will follow that up and I'll get back in contact. Thank you, Amy, so much, and thank you to all of you for sending through your questions. We will send out an email to you and ask you how you enjoyed this evening, what we could have done better, and what you would like next. And we really appreciate you joining us on International CLL Day, and that you've taken time away from Father's Day to be here. So thank you, all of you. Thank you, Amy. And yes, we look forward to having another session with more progress, maybe September the 1st of next year, if not before.
Thanks, Ruth.
Lovely. Thank you all.